Well, this has been a great discussion. We have reviewed the published clinical evidence, discussed ongoing clinical trials, reviewed case study reports to evaluate the role of targeted therapies in the treatment of metastatic kidney cancer, and I want to thank my panel for participating. I think this has been robust, and I think you've all come at this with, from the perspective of trying to educate our friends and colleagues in the community that have to take care of these patients. So let's start with you, Dan, and see if there's some closing thoughts that you have.
Sure, Bob. I think, I really appreciate the discussion. I think we covered a lot of ground here. If I had to pick a couple of highlights, I would say, in terms of kidney cancer, we have one of the widest natural histories of solid tumor out there, both in age of diagnosis and in the natural history of this disease. Understanding risk stratification up front, I think, is really helpful for patients and prognosis. And I think that's really important to do in that early visit. I think the other sort of key message that came out was early observation of patients on therapy for side effects. We saw, with our patient-reported outcomes that the hardest cycle of VEGF-targeted TKI is the first cycle. And having patients come back at that 2-week period is so critical, both to catch those outliers that have bad LFTs or other issues in terms of drug exposure, to sort of catch that sort of toxicity profile where they're going to be much better off on that 2-1 cycle and whatnot. So to me, sort of those are sort of some of the key management questions there. And then I think where we're struggling, where we still need more data in terms of understanding the right sequence and what to do with those patients in third line and beyond. Questions where I think we'll have some more data. We have a lot of hope around new therapeutics. This is worth tuning into next year. We'll have more data. But I think for right now, this is a field that, with multidisciplinary care, with collaboration, these patients can do quite well for a long time.
Monty?
Yeah, again, I agree with Dan. This has been a really great session. I wanted to actually just highlight something that you actually brought up earlier, which is that not every patient makes it to third and fourth line therapy. Just to put some numbers to that, we think that somewhere in the ballpark of 50 to 80% of patients will get onto second line treatment, 25 to 30%, a really daunting number, will actually make it onto third line therapy. So I really think it's critical as we reach out to our colleagues in the community to underscore some of the exciting clinical trials that are happening in the first and second line setting, incorporating some of these agents like PD-1 inhibitors, c-MET inhibitors, et cetera. If we don't see these patients early on, they may be denied the opportunity for these studies.
Brian?
Yeah, similar thoughts. I think learning a lot about specific drugs is important and how to give them. We've spent a lot of time talking about getting a high level of comfort and expertise in dosing and scheduling and when to stop and when to start. And more important than whether you use this TKI or that TKI in frontline is a comfort level in the one that you use, and not shortchanging patients on the opportunity for adequate exposure to a drug. I've worked a lot with axitinib, but as much as I've worked with it, I'm still figuring out how to give the drug. It takes a long time to really figure out how to give drugs, and so you really need to dive in with specific drugs. And then, as Mine just said, really just a plea for clinical trials. We're a long way from solving this problem. We've definitely made some advances, but once we get beyond first line, it's really fairly dismal. We have anecdotal responses, but the PFS in second line and third line is really not that great. So there's some new exciting agents coming, and we're looking forward to sort of the next generation.
Nizar?
It's an exciting time to be in oncology, and particularly to be treating patients with kidney cancer. 7 FDA-approved agents in the clinic. And there is no question that patients now are living longer than before. And they are living longer because of these agents that are now in the clinic. And this is why I think we should continue to encourage our patients and their treating physicians in the community to refer them for clinical trials. The future is bright. On the horizon, we have, as we discussed, the immune checkpoint blockade antibodies and other target agents, and how we combine them and how we sequence them. So I think we still have a long way to learn. But unless we continue to encourage our patients to participate in the trials, we will not have the opportunity to have new therapies in the future. I think the difference that we have seen between treating patients at academic centers, such as what you heard today, and in the community, is that Unfortunately, we have published on this and we all discussed this at these venues. Patients in the community, unfortunately, do not stay on a proven drug long enough, as long as they have on trials or in the academic centers. And it's primarily because the patients and the physicians give up quickly on a good drug. And I think it is key. We talked about how we minimize toxicity, how we manage these adverse events. I think it's important to not give up and switch drugs quickly. Stay the course, manage whether by altering the schedule, aggressively managing the adverse events of diarrhea and even fatigue, treating hypertension, treating diabetes mellitus. These things have to be done. So we have to be really good internists, good physicians to keep patients on drugs that are working rather than give up. So finally, I think we need to thank the patients and their families for supporting clinical trials. And we need to thank also our community physicians who we partner with.
And I would just say, from my own perspective, having grown up academically in the era of cytotoxic therapy, where a person comes into the office and every X period of time you give them something intravenously, there's a real art to delivering oral targeted therapy. And the art is really only obtained through experience. There's only so much that prospective trials can give you, and the balance is really the art of medicine. So I would just say to all of you that are listening to this, reach out to us. I think that most of us are comfortable interacting as necessary on behalf of your patients. Try and find ways to offer them the best opportunity for a positive outcome, and recognize that we're still on the learning curve, as Brian pointed out. Here we are 8 years after a TKI was approved, and we had a significant piece of our discussion talking about a novel approach that has only now reached retrospective analysis and published in the literature. There's a lot still to be learned. So on behalf of our panel, Dan, Monty, Brian, Nizar, we want to thank you for joining us, and we hope you found this peer exchange informative. God bless.